Welcome everybody. This so I haven't presented on this before, so what I'm going to do is sort of take you through what I think is important to present quite slowly, and invite you to kind of chip in, possibly in the chat if you want to. I can see the chat because I've got two screens, so with questions or put your hand up. So this is not focused on teaching you how to do data science or analyze health records. It's a sort of more conceptual talk on like understanding what impact means and how we could embed impact into a kind of health data science pipeline of knowledge generation, and hopefully change in the health and care of our local populations. So what I want to cover is basically some definitions to start with. So understanding what impact means, what health data science means, what we mean by routinely collected health and care data, and other types of health data we might want to use in health data science. And then some sort of conceptual issues around the types of health research questions we could ask of big data that would produce knowledge that's sufficiently kind of robust and reliable that we would then start implementing health and care changes as a result of it, and how we might build projects and teams that can deliver impact in that kind of pipeline. There will be a couple of places where I ask you to contribute your ideas throughout, and you're welcome to put up your hand or put it in the chat. Okay, so what is research impact? You've probably covered some of this already this week, but so NIHR on its impact vision talks about research having real world effects, making a meaningful difference in people's lives and contributing to improving health and care for the population. And I thought I'd sort of look at what impact means for the community that does research using healthcare data. So health data research is a UK-wide initiative and sort of funding hub for a lot of health data research, and they want to produce research that provides demonstrable positive effects on data science methods and technology, public trust, health and well-being, decision-making, and research culture and capacity. So I found that interesting because, health and well-being, I would certainly be the central aim in terms of impact for NHR, but as only the third most important here. But you can see other things that we can be aiming to do with our developing methods, increasing public trust in our research, and improving research culture. So how do we generate impact from research? So new knowledge needs to be generated. We need to create new knowledge and insights that are robust and reliable, and we believe, are really true and represent what's real. They need to be contextualized. So the new knowledge needs to be understood in a context where it's kind of actionable, and then it needs to be put into practice. And I've sort of conceptualized this as like growing a tree. You need all the right conditions for that tree and plenty of time for it to grow bigger. And then you get the fruit that comes off at the end, which is the kind of impact. And in my experience, we need a huge diversity of roles within our teams to make this happen. And this is from the NHR Impact Vision video that you'll be able to find on the NHR website. I've just taken a screenshot, but they're showing all the different people we need involved in order to create impactful outcomes from our research. And so I want to focus a little bit on our kind of stakeholders. Some people don't like the term stakeholders, but I quite like it because I always go back to this question: who has a stake in my research? Who has a stake in what my research does, produces, or shows? So having a stake in something means having an interest, an investment, or an involvement in something, or that something is important to you. And our major healthcare stakeholders are patients, providers, policymakers, and payers. It's an American spelling, but the people that are funding what gets delivered. And I always think at the beginning of a project, you need to be thinking who will be your end users or the users of the knowledge you create. It's never too early to involve them, especially with something like health data research, which can seem very office-based, behind a computer, never really getting involved with real people. And the ARC, as an institution, funds applied health research. And this is similar to sort of embedding impact throughout your work. In the applied health research aims to create research that addresses immediate issues facing the health and care system. It's quite a practical approach to research rather than sort of, say, theoretical research or blue skies research or very early stage research. It's on the coalface looking to find practical solutions for existing problems. Okay, so that's sort of going over what I'm talking about when I say impact. Now, what do I mean by health data science? Now, I can see some of you in the audience I've worked with on projects before, so you're definitely going to know this, but let's just go over it anyway. So health data science is the application of data science methods to healthcare data. So this involves collecting, cleaning up, don't underestimate that stage, analysing and interpreting large data sets. The most common aims of projects in health data science are around disease diagnosis, prognosis, and, for example, identifying determinants of disease and or their outcomes, drug discovery and development, personalised medicine, so that might be sort of stratifying or predicting risk in people or trying to predict what the best treatment might be for their particular condition. It can also be used as a sort of back office function of kind of trying to improve efficiency of how systems are working. And it can be used to address public and population health challenges, such as epidemics and healthcare disparities or inequalities and care for chronic diseases. And I think using population data sets became very apparent during the COVID pandemic, when a lot of NHS data was used to track what was happening and what was working. So health data science sounds kind of techy and cool, but it's based on statistical analysis. So anybody who's had a decent statistical training can get involved. Often the first stages are descriptive statistics about, counting up how many people are in different groups, and then hypothesis testing, seeing if groups differ on certain characteristics, regression analysis. Can we predict things? Can we show that something is influencing another outcome? Survival analysis of, can we predict how long it's going to be until an event happens to somebody? And then we can move on to more data-driven approaches. So statistical analysis your decisions tend to be based on clinical knowledge and expertise. So you choose your variables and your tests because you have a hypothesis and a prediction of what's going to be shown. So machine learning comes from a place that's more like, oh, we've got all this data, let's see what's most important and let the models kind of derive themselves. So that's what machine learning is about. If I put these weights on the predictors, do I get a good result? No, let's go back and try again until the data has shown you what the best predictors are by the strength of their associations. So we have different approaches: classification, that's saying this patient should be in that group or that group; regression, clustering, deep learning. Natural language processing is another form of kind of AI machine learning, which is about extracting and structuring up information from unstructured text data, so plain language data, such as medical notes, reports, and letters. And then we also have data visualization, so sort of creating dashboards and visual representations of data to communicate findings effectively in reports and clinical notes. So, what's happening to which group of patients, and is it, are the relevant people getting their right health checks? How many people have had this happen to them or that happened to them? So they can be a good way of showing live data to people who need to action that in real time. So what I do in my research and what we've been trying to grow in the ARC is the use of routinely collected health and care data. and its use in research. So this is data collected in the course of interactions with the health service. This could include GP clinic notes, their prescription data, and the coded data that goes into everybody's records at each time that you interact with your GP clinic. There's quite a lot of structured or coded data in a hospital. So the hospital system needs to record its activity in order to get paid for that activity. So you've got a kind of driver there of good recording in order to get payment. And you get files from the emergency department, outpatient care. So that's when you just have an appointment in an office. Inpatient care, when you might stay in. Discharge summaries, and then things like scans, lab tests, pathology reports, so investigations that go on. There's also mental health patient notes and some coded data. We could be looking at nursing records. So, for example, there's a huge database in America that's available called Mimic, that's intensive care unit nursing records. So hour by hour, day by day checks on patients. And disease registries and social care data. So we're lucky in Sussex and in Kent as well, but I'm going to talk about Sussex because that's where I'm based, in that there's been a lot of work gone in the last 4 years in linking together those sources of data from different parts of the healthcare system, so that almost every NHS provider in Sussex is now contributing data into something called the Sussex Integrated Dataset. Now, the data is anonymized at source. So the names and addresses of patients are not extracted out of the healthcare setting. The data goes into another part of the NHS. It's not taken out of the NHS, and it's all linked together. Patients are given an encrypted sort of pseudo ID. And this is developing over time and should be shortly available for us to use. It's easy for you to use if you're an employee of an NHS provider in Sussex or in a local authority. It's a little bit more complicated if you're not a sort of internal analyst. But there's a secure data environment coming on stream soon where researchers can apply for access for this data set. So you can see here we've got in the sort of light purple mauve, they're all the GP records feeding in. This down here in this corner of sort of pinkish, they're the hospital records. Emergency is the ambulance service, and we've got social care coming from the local authority. Community trust, mental health data, limited mental health data, and I'll explain why in a bit, and referrals data. So in our area, we're actually doing really well in terms of data that's becoming available and usable for research, and it's worth having a think about that. Now, there are, of course, other sources of health big data. There's a lot of, globally, there's a lot of work on using data science approaches for image analysis. So actually, machine learning works really well on image analysis, and you can get really highly accurate sort of predictions or classifications from images like brain scans or mammograms. But we should also consider like patient-generated data. So we've got wearables. I don't know about you, but I wear my Fitbit, and it records all sorts of things about my life outside of the healthcare system that are health related. And sometimes I put self-report data into the associated app. Then people can go online and fill in screening tools or play games that record things about them. So, for example, one in terms of looking for cognitive decline, one of the symptoms is like a lesser ability to navigate in space. So there's you can play a game where you're trying to navigate around a game in space, and it will give you feedback on your cognitive status without having to use any language, which is quite interesting. So those kind of things are coming online. Some people will analyse social media data about people's experiences of health, and increasingly for the elderly population, for keeping an eye on things like dementia and frailty, there can be in-home or in-car sensors. And as our data science methods improve, we can also consider combining sources of data as well. So what might we want to do with these data sets? Well, ARC has shown an interest and funded a program of work with local routinely collected linked data sets to do the following things. So one, use them to identify underserved and at-risk communities and groups. For example, those living in coastal towns might be less well served by healthcare at the moment. So another thing is to conduct baseline assessments of where we can target implementation projects that have been developed in the ARC. We can use these data sets to develop digital technologies for early detection and risk stratification. So we've been doing projects on dementia, we've been doing projects on first episode of psychosis, we've been doing risk prediction of falls in the elderly. And we can then look at downstream effects of interventions, of how people have then gone on to use the health service, which could give us economic outcomes or show that a particular intervention would reduce the need for healthcare in the future, for example. So the idea is that these types of analyses can underpin well-informed implementation of interventions, early disease detection, personalised care and preventative care, and show us that our local interventions are cost effective. So now I want to go on a bit more to talk about the sort of health questions we can ask and answer with health data, because you can't take these data sets and answer any question, ask of them any question you like. You've got to consider what's in them. So we need to form our research questions around what is in the data and how it's been recorded or captured. We're stuck with what is in there, so we can only ask questions, research questions, if the data has been collected and we know it's there in reasonable quality. And you've got to remember that health record data, so your patient records, are recorded by the clinician. So having information about somebody's condition, their health condition, their diseases, depends on the patient telling the clinician and the clinician recording it in a format that we then extract, so in a code in the record. So what we have developing in Sussex and Kent are these integrated data sets that I told you about before, but they only capture structured data. So structured data means data that's gone into set fields in the record or the kind of billing form or whatever. And in, say, mental health care, that means just diagnosis codes or like reasons why people got admitted to hospital, and all the rest goes into completely unstructured, just typewritten patient notes. And it's quite similar in general practice. GPs can record with a mixture of codes. They have a huge coding set of things like, symptoms, diagnoses, processes, tests. But they also can just type in notes about the patient, and those notes are not extracted into our data sets because they are considered too much of a privacy risk. The clinic notes for mental health care in Kent and Sussex are being extracted for research, but not in the same data sets. They're being processed by a company called Acrivia. They host that free text clinical data in a safe haven and apply AI analytics to it to structure it into things like symptoms, signs, substance misuse that can be presented back to the NHS trusts for analysis. So if we have a mental health question, and really what we want to know is how do people progress and can we follow them up for a long time? The answer is probably not that well, because although we've got all this detailed mental health care information, it's not linked. So I've got these arrows showing it's linked, but it's not currently linked to the GP data. The other thing we need to remember is, as I said, the data is recorded by the clinician. So you've got the patient with all their symptoms, and they go and speak to a clinician, a GP, say, and exchange information with that GP. The GP filters that clinical information because of their medical knowledge and understanding, and puts some of it in the patient record. But we don't quite know how much has been captured by the GP of the truth, the underlying ground truth in the patient. And we don't know how much has been filtered when it went into the record. And when we extract out the codes, we don't know how much we lost because it went in the free text, which we're not extracting. So I see Gayasha is on here, and here's a question we've been discussing for her PhD. So men's experience of urinary problems and erectile dysfunction after prostate cancer treatment. If we want to find out about this using GP data, what might affect the numbers of men we find with these symptoms and the characteristics of men that we find with these symptoms if we use anonymized GP data? Gayasha, you're not allowed to answer because we've already discussed, but can you have a think about, what might influence these experiences of men and that pipeline of it getting into their GP record? Can you type something in the chat or put up your hand? Accessibility to GP. Okay, good. I'm going to quickly drink my tea while I wait. Yeah, so Beth says, how many of the men come to the GP with these symptoms? Yeah, so these are really stigmatized symptoms. Like nobody wants to talk about them very much. So what type of men might come forward? Would there be a sort of set of characteristics that might predict who would actually come forward? Yeah, so Hassie says some of this data collected by female nurses, men might not want to talk to them. So while these symptoms might affect anybody, any men afterwards, after prostate cancer treatment, there might be only certain types of men who are confident enough to come forward. And so if we look at GP records and say, oh, only these men have these symptoms, we would have introduced bias and our knowledge wouldn't be very reliable. So just thinking about that a little bit more, and I don't want to put you off using this data. It's brilliant data, but you need to go into using it with your eyes open. So we know that there are constraints on what data gets entered, not just of what men might come forward to the GP with symptoms, but also the coding structure that the GPs have. You can see on this slide some sort of different, when I say codes, what I mean. So we've got down in the middle here, personal history of allergy, type 1 diabetes, dengue fever, streptococcal sepsis. We've got the interface, the sort of human interface with the patient record system, which might favour typing in notes or favour coding things. And then we get sort of different output. The time available for documentation, we know everything's rushed. The motivation for documentation, are you just informing the next clinician what you saw? Are you keeping a record for your own memory? Are you coding stuff because you need it for billing? Are you safety netting yourself? Clinical reasoning and filtering of information, and then whether they're considering the use of this for secondary purposes or not. And let's just remember, I always say this, and again, I don't want to put you off, but do this with your eyes open. We know that structural biases in healthcare exist, and they will also replicate in the data that we extract. So we know there can be biases in terms of race and ethnicity. We know there can be biases about gender. We know there can be biases in terms of LGBTQ community, disability, body size, and income. So how do we form a good research question with our eyes open looking at this kind of data? So I would say a concise question is very important. And why is that? So it's no good going, oh, I'm just going to, have a look, see what's in there. Why? Because if you receive 3 billion rows of data, which, you know, the SID has, what are you actually going to look at? You do need in advance to define your variables, and you need to define them usually using lists of clinical codes in terms of like symptoms and signs. Oh, I can hear somebody. Oh, hi, Harm, welcome. Carefully plan in advance your exposures, confounders, and outcomes. And so this is another question we're just struggling with at the moment. So we want to know which mental health symptoms are most associated in young people with referrals to secondary care mental health services. So again, you know, which symptoms will you choose? How much do you think GPs record symptoms or might put them in the clinic notes, which you don't have access to? Are you going to just have like classic sort of low mood, anxiety type symptoms, or are you going to look broader because we know presentations in young people might involve somaticization? So how about physical symptoms, tummy aches, fast heart rate, neck or jaw stiffness? But if you include them, how do you know they're linked to mental health? And how would you know if they're mild or severe? So you've got to think of these things in advance. And what I would say, I'm going to come back to that slide in a second, but I would say definitely get clinicians on board to help your analysts understand the clinical workflow, like how this consultation might happen in practice, what the drivers are of those clinicians, different decisions, referrals, treatments, and therefore recording. Ask frontline clinicians to help with code lists and variable definitions. And have a think. So Hessie has put in the chat around more holistic, wider determinants of people's health. And that is hugely important. And I really want to include that kind of information in my studies. However, that might not be routinely recorded in a clinical record. Social information may be less likely to be captured and only for certain people. And if you only include those people for whom it's captured, is there something special about them as a group that would, by only looking at them, would introduce bias into your research? And the other question is, you know, how granular is the data? Now, when I say granular, I mean sort of fine grains, like to what level of detail does it go down to? So, for example, if you want to look at, you know, mental health reasons for A&E attendance, but all you've got is a code that says it was a psychiatric attendance, you're not going to be able to answer that more granular question of which are the symptoms that took people there. So what I'm saying is this should be a team sport. You know, have frontline clinicians and commissioners determine the questions you ask and help you drive the kind of the variables that you choose, your exposures and your confounders, and then you will generate knowledge most likely to be actionable. So the other thing I wanted to say here is lots of people say, oh, I've got all this data, I've got all these different pieces of information about each individual. Perhaps I can make a prediction or predictive model, risk stratify people, or say something about what's going to happen to individuals. So I completed this slide, which you can look at later, but before you decide to make a predictive model, I would suggest you stop and say, what do you want to predict? Are there good quality data representing that outcome? Because if you don't have that, then it's really difficult to train a model because you can't teach it what the right outcome should be. And then go back to your clinicians and your team and say, does any end user actually want the prediction? Is there any point in making that a prediction? Are the useful and important predictors well captured? And once you're predicting it, will it help workflow or add extra pressure to the system? Do you have the resources to care for somebody who flags positive from the model or high risk and change their outcome? And I will tell you why I ask you these questions throughout my case study that I'm going to present in a minute. So one of the things we're trying to do in the ARC is using data to address healthcare inequalities. And one of the great things about these linked data sets is you can track patients' care through multiple providers and you can spot where they fall through the gaps. So this is what's called a theograph. I'm not quite sure what it's called that, but it's where you plot the time along the bottom and then the different services that have contributed to a patient's care using symbols. And then you can see where, so for example, where social care is kicking in after the patient's had an emergency admission to hospital or an A&E visit. Or you can see where they've had a referral for mental health, or where they're getting community nursing visits, and how those things are interacting. And then you'll be able to have a think about, you know, where people are falling through the gaps in services across the whole system, and try to improve that. Another way of using these data sets is looking at rates of multiple long-term conditions. So some of you will have seen this graph before, but it's basically a plot using real GP data in Sussex, where you have the age across the bottom of each patient, and then the number of long-term conditions is plotted up the side in terms of the percentage with that many. So you can see when people are young in yellow, they tend to have fewer conditions. And then by the time you get up to sort of 80, almost everybody's got at least one long-term condition. And then they've, like, a lot of them have 2, 3, 4 or more. And what you can do is you can see where, by the slopes of the curves, you can see if this sort of multi-morbidity or burden of long-term conditions is happening earlier or younger in that group of patients than somewhere else. So we could look at, say, coastal GP practices and see, you know, are people developing these long-term conditions earlier there than in other places? And then we can start distributing resources differently to try and reduce those inequalities. So this is a case study of a number of projects that I've been doing over the years around predicting or dementia or early detection of dementia, which is sort of on the cusp of producing impact, but it's not clear how it's best to do so. So I want you to listen to the different stages of the project and then think. I'm going to ask you at the end, what should we do next? How could we generate impact from this? Or just what are your thoughts, to be honest? So, case study, predicting dementia. So in 2016, I got funding from the Wellcome Trust for this project, AstroDem. This is why I'm wearing my Stars and Moons shirt. Using astrophysics to close the diagnosis gap for dementia. So this was a project where I collaborated with physicists who use their data science skills to analyze GP data, to try and create models to detect dementia earlier from the other information that was in people's GP records. And this was we thought this was really important because currently, even now, diagnosis is often made at a time of crisis, when people are struggling to cope, and usually too late for the person with dementia to express their financial and care preferences and make plans. So we want to detect or predict dementia earlier to allow patients time to plan, express their wishes and organise care, to enable access to disease-modifying treatments where and when these become available, and potentially to recruit them to clinical trials for these new treatments because they're most likely to work at an early stage. Over the course of discussing with GPs and looking at records and thinking about this, we realised there's actually several stages to getting a dementia diagnosis. There's the time when patients are developing dementia, but it's not recognised by anybody in the system. And then there's also a period of time where the symptoms are recognised by the GP, but there's no formal diagnosis, either because the patient is not really ready to go into that formal diagnosis process, or because they've been referred into it and they're waiting for it to happen. And then you get the formal diagnosis of dementia eventually. So if you look at a primary care patient record in the 5 years before dementia diagnosis, there may be a number of signs that dementia is developing, but that don't indicate that the GP is already aware of it. And this would be the place in time, the opportunity to tell the GP of something they don't already know. Whereas closer in time, you can see that they're starting to have those discussions and the GP is aware of it. And at that point, there's kind of no point in telling the GP, oh, this person's developing dementia, because they clearly already know. So we were trying to work on that earlier time here to see if we could create a model that could discover people that were developing dementia. So we started with about 95,000 people's patient records. So we had their GP records for up to 5 years prior to their dementia diagnosis, and 50% of them ended their record with dementia, and 50% of them did not have any evidence of dementia at all. And we used several data-driven methods to work out what the best predictive model was. So we started with a logistic regression, and then we used some other machine learning models and assessed these using something called area under the receiving operator characteristic curve. These are the types of predictors we used. So prodromal symptoms of dementia, prescriptions, indicators of reduced coping, other conditions that are known to be linked to dementia, social factors, and historical factors. And this is the receiver operating characteristic curve. Basically, if it's 50%, 0.5, then your model's just operating at chance. And if it's 1, then your model's perfectly discriminating between the people in the two groups, so the dementia patients and the controls. So we managed to get about 0.74, which is considered reasonable, but probably not quite implementable in practice. So then this was taken forward, our work was taken forward by a group, including Harm, who's in the chat, who's here, and our colleagues in Manchester, who continued this work in a project called DemRisk, which was funded by Alzheimer's Research UK. And so what they did was they had a cohort study. So they selected older people, without any particular characteristics, and followed them all up for 5 years to see if they got a new or first dementia diagnosis. And they did this on over 1 million people, and they evaluated 60 risk factors. And what they were saying was not that these people have dementia, but they're at high risk of dementia in those 5 years. So they had using a different kind of analysis. So their measure of accuracy was called Harrell's C, a concordance index. They got 0.78 in the group of people aged 60, 79. And they said in the top 1% of risk scores, so the patients who were highest risk, 37% of them would go on to develop dementia in 5 years. And in the age group 80 to 89, the model discrimination was lower, but because prevalence was higher, they found that in their top 1% of risk scores, people with high risk scores, 79% of them would go on to develop dementia. So you can see we've worked to develop these predictive models of who's at risk of dementia in primary care using GP patient record data. So no burden on the GPs or the practice nurses to collect extra data to populate these models. But then I started thinking sort of more holistically, is the prediction or detection of dementia a good idea? So I wrote this review around using digital biomarkers and artificial intelligence for early detection of dementia, and sort of put a framework around how we should do this ethically, because, as this sort of visual abstract shows, if the AI is popping up and saying you have early dementia, you've got quandaries there, both for the clinician and for the patient. And as I'll go on to show you, in terms of like the biggest question that this generates is, well, what should happen next if somebody's at high risk of dementia? The other issue is, do GPs actually want this as a predictive model? So we've done 2 studies now. One was an interview study with GPs saying, if you get clinical decision support, which is kind of a bit like AI, but can be sort of rule-based, in your patient record system. So it pops up with advice or forms to fill in or things you're supposed to do. Like, what's the best way of integrating that in your workflow? What features and functions of these clinical decision support systems do you want to see to actually use them, rather than spend 10 minutes at the beginning of your session shutting them all down so they don't pop up, which is not what we want if we think this is valuable. And then very recently, we finished a study that was funded by the NHR on views of key stakeholders around this specific tool, this DemRisk tool. So semi-structured interviews with primary care practice staff and primary care patients in Sussex, Greater Manchester and Newcastle or North East area, asking both groups, how do elderly patients and carers feel about being offered a routine risk assessment populated by this DEM risk by their GP to assess their chance of developing dementia? What would be the main benefits and drawbacks of a tool? How should the results of the tool be communicated, and what should happen next? So healthcare professionals generally said, yes, we'd like such a tool, but only if there's an intervention. Yes, it could help people find out about modifiable risk factors and therefore change their lifestyles and ideally be able to change their risk and feel like they're doing something positive. So as a result of that, if you can't do anything about genetic or fixed risk factors like level of education, for example, it's much better to look at modifiable risk factors. Some people therefore may be able to turn the risk around. It would be helpful to have a routine risk assessment tool, which could lead to earlier diagnosis and possibly some good treatment. And it would help families because they'd be prepared. But mainly, the main message was, yes, but only if there's an intervention or resource in order that when people flag positive on the model, we've got something to offer them. And patients had some mixed views. So they said, yes, I would want to know. Almost everybody interviewed said, yes, I would want to know, but some people wouldn't, and we need to take their views into account. And the reason for this is that they were sure that some people would be very anxious about it and they might not want to find out. So it should definitely be a personal choice whether people want to have it done. Other people said it's helpful to know your risk so you can take more control. But of course, not everybody has a huge amount of control over all aspects of their life. Other people said dementia's awful. It definitely needs something. You've got to start somewhere. So I think this kind of assessment is a start. And also that if medications could work better at an early stage, then that means it would be better to assess people and find out early. Okay. So again, put your hand up and say something, or put in the chat. What should we do from the next steps? It's a real question. What should we do to that this project should have some impact? What would be the best next stage? I've got some ideas, but I'm just interested in what you think. Don't be shy. No ideas? Hi. What do you think our next project should be?
Hassel's got some suggestions in the chat, I think.
Yeah. So something around better, less inaccurate recording and capture, care on building data and knowledge, more training on data capture. Yeah. So having presented on this a few times and had feedback and comments, what I would now like to work on is what should that intervention be when if you're going to predict someone's at high risk of dementia, what should we do for them? Because all of these data questions produce real effects on people's lives. I mean, we want them to if they're going to be impactful. Harm, what do you think Harm is a GP, for those of you who don't know him. What do you think good care, like decent quality care for somebody that's high risk of dementia would look like?
Yeah, it's quite complicated. I think many people with high risk of dementia or early dementia or minimal MCD, minimal cognitive deficits probably most of them actually don't really want to be talking about it. So that makes it complicated. It's not a linear thing, and I think there's probably also like a training gradient. Yeah, people with higher education might be more worried about their memory loss and want to do something about it, and people with less education might be less inclined to think that's something they can control. So I would be really interested in seeing how it works in practice, actually, to see how people respond to this offer, like a bit like the health checks offer.
Yeah. Yeah.
And what they think of something like that. And usually what happens is that the worried well come forward, and people who are already quite healthy will want the checks, and people who are not worried well will not want the offer.
But it's difficult, isn't it?
Yeah, but I would be interested in testing this out in the real world a little bit more and seeing how people respond to that, or what could be tailored around a new pathway for dementia risk. I would think, it's a difficult thing because the risk, it's already difficult to sort of conceive what your risk is when it's sort of in a year's time. But this is a long stretch as well. It's
5 years, yeah.
Yeah, it's far in the future. Does that make sense? Or
yeah, totally. Thank you, Hasu.
So I think people with dementia don't automatically present themselves directly. They will know that there's a problem in memory and all kinds of things, and it's really the family member, the close partner, who will be the interface with the GP or any other doctors, and they will be making all the decisions. And I think when you use AI in terms of a predictive model, but it's rather like Tesla at the moment, they're trying to do autonomous driving, but it's not 100% accurate, and there could be accidents. So as long as there's an override, so I think the predictive model, I think, is very useful, but it should not be a complete and the only intervention. It should just provide the risk factors so that the professional then can make a judgment. And I think in those cases where people are not manifesting severe symptoms yet, but according to your model that they are at risk, rather like they're doing this in cancer as well, then and so they may be reluctant to want to take medication, but they may be open to suggestion for other kind of lifestyle changes that might actually prevent. So I've seen somebody with dementia doing sporting activity and is doing remarkably well compared to another person who is at home all the time, who is deteriorating, and they're all kind of similar. In fact, the person who's deteriorating is on double the medication. And I've been amazed as to how this person has been kind of getting better and better in communication and physical activity and all that. So I was quite staggered to see that the brain can actually change in terms of physical activities as well. So there are these things that can come into play, and therefore what you are doing is providing really useful information to the professionals to then make a further refined diagnosis.
Yeah, that's really important, isn't it? So keeping the human in the consultation and not letting the AI take over the agenda, I think, is really important. Okay, so I can see that we're coming to the end of our hour. So just a couple of messages to take home. At what point in our study should we do this sort of end user engagement? I think I've probably made the point that we need them. We need our end users, both patients and healthcare providers and commissioners in all aspects of our research, but especially around the beginning, the conception and design of the research. Now, if this is giving you a flavour of the kind of projects you can do and you want more help or you want to get access to data, we've created a website, the ARC Data Hub, which gives you information about different data sets that are available. We'll give you my contact details. You can get in touch with me. We'll give you advice. And then also, very excitingly, you can find out about this Kent, Medway and Sussex secure data environment for research that's making these data sets available for people in universities across the whole of England. In fact, that's the website there. And I think Debbie will share these slides, so you'll have that link. So that's the end of my talk, and I'm really welcome any further comments or questions.